with a PSA above 3, I'm not saying all of those who are having PSA above 3, sorry, between 2.1 and 3, they will have prostate 19.1% of high-grade disease. Now, once you go lower, the percentage of the prostate, the high grade will go down, which is what we want to capture. We want to capture the high grade, not the low grade. Next. So now there are derivatives that we always see: PSA density, which is the total amount of PSA with the size; PSA velocity, which is, I use it a lot. It's the how fast is your PSA going, and it's very, in my opinion, it is a good derivative. So if it's above 0.75 nanogram per year, it is significant for me. Now, this means you have to do multiple PSAs, which is important. The whole idea is that you don't take it from one reading. And then we have the age-specific cutoffs, because you know what? The PSA for your patient who's 75 is different than the PSA for your patient who is 45 or 55. So as we get older, we accept higher value. Like if I have someone who's 75, I can accept up to 6, but that does not mean if somebody comes at 6 and oh yeah, it's normal. I will check and I will repeat, and I will see the velocity and the trend. The trend is what makes a lot of sense to me. Next. Now, this is not important. I'm not going to get into this because this is going to be more details. I'm going to talk about this a little bit later, but just briefly, the free to total ratio is also important. And we know that it is significant when it's in the range between 4 to 10, like when your PSA is between 4 to 10. So it is also one of the adjuncts that I use in the decision. If you have a lower free to total ratio, less than 11%, it is higher sensitivity for significant prostate cancer. If it's above 25, it is less. But I don't use the free to total ratio as the reason I do a biopsy. I use the velocity, the cutoff, the free to total. All of these things, they are used together, and the density as well. Next. Now, we have other tests like PCA3, Pro-PSA, 4K score. If you have a fancy patient who goes to Toronto, they might tell you, oh, I went and I paid $1,000 and I got the 4K score, or prostate health index. There are gazillions of those, and none of them have hit the guidelines. They are mentioned, but they are not part of the guidelines because they're expensive, and the utility is not as, I think it's very specific for those who can afford that kind of thing. Next. So when we look at the prostate cancer, this is basically how, it is significant amount, you can see, it's actually, the deaths is not as significant, but the new cases are significant. And this number has taken a hit in 2012 when we had the task force, which we're going to be talking about. Next. Let's move for the next one. So in 2012, the US task force came out and said, we looked at the two major trials, the biggest trials in the world for prostate cancer screening, and we have come to the conclusion that we do not think we should be doing PSA screening. So there was a major issue with this statement, because the task force that made the statement did not have a single person on the task force that was a urologist who understands the research that was done or the issues that can happen with these trials. So you can be a researcher, but if you don't know what's happening in the clinical aspect, this will be an issue. Let's go next. So they said it's a grade D recommendation. It was a grade D recommendation, but everyone, family doctors, nurse practitioners, they said, hallelujah, no more PSA. We hate PSA. It's always confusing, and there are a lot of issues with the PSA. We don't understand what's happening. This is the best thing ever. And right away followed family medicine guidelines and all of this. Like we said, oh, we do not recommend any more PSA screening. Next. So basically a D rating, and they were heavily using two studies. I'll call them the PLCO and the ER-SPC. The PLCO is the North American study, the ER, or also I'll call it the European study. Let's go next. So they basically said that biopsies, that you do PSA, you do biopsies, you get the majority are negative. There's a lot of bleeding, infection, and then if you can do prostate cancer treatment, you're gonna have complications, erectile dysfunction, urinary incontinence, or stenosis. It's not good. So we should not be doing this. We're actually harming men more than we're benefiting them. Next. So they said basically in 10 year, with the studies, this is how when they put the data together, they said in 10 year, you can, if you don't screen, you will have like 5 in 1,000. And if you screen, you're going to have 4 to 5, so the benefit is 0 to 1. And then look at the harms. False positive, 100 to 120 in 1,000. Prostate cancer diagnosis was 100 in 1,000. Death was less than 1 in 1,000. Incontinence was 18. Erectile dysfunction was 29. This is from screening. Next. So they basically said that's bad. But let's actually face let's look at the studies, and we're going to find out why this statement was not the correct statement. Next. So this is basically the European study. Let's go next. So they had 160,000 men in Europe, 7 countries between 55 and 69, and they said we're going to screen every center. They will have their own protocol. They were going to screen every 2 to 4 years versus the usual care. So they basically looked at the compliance in the screening group. They had 82% were actually screened. And in the control group, they don't know because it was whatever the usual is. And then they have a median of 11 years. They found that, the incidence in the screening, you detected more prostate cancer, 6,900 versus 5,300. So this was basically significant detection in the screening group. Next. Now they looked at the screening reduced the prostate cancer specific mortality by 21%, but the benefit was low, as we said before, 1 out of 1,000, and you need to invite. Initially they said 1,400, but then they did reanalysis and they said you need to invite to screening 1,055, and you need to treat 37. So this way so that you can save 1. Numbers look horrible. Who would do that? So they said, oh yeah, the screening increased the incidence, but patients died anyway or did not die. So what's the point? Next. Let's go next. It's not gonna make the difference here. So the limitations, basically, in this study, it was a good study, but it had variable randomization. Each center, it's not even each country. Each center in the study, out of the 7 countries, had their own randomization strategies, testing intervals, biopsy criteria. So it was not really very. It's not very strong when you do this kind of thing. It's so big that you have so many, like such a huge number, it will dilute everything. Let's go next. Now, we want to look at the North American study. Next. So this is basically 13 years. This was a big study looking at prostate cancer, lung cancer, ovarian, and colorectal. And it was basically run for 13 years and even longer. We have even longer follow-up for this. Next. So they looked at men from 1993 to 2001, 76,000 men up to the age of 74 in 10 American centers. Annual PSA plus DRE versus standard of care. And you have to remember, Catalona, the guy who, this is a guy from the States, he's the US were the ones who did the PSA. So they're the ones who actually made it get approved in 1994. So everyone was getting PSA screening. Even so, when you're talking about versus standard of care, the rate of PSA screening in the standard of care was actually high. And then you do a biopsy if you have an abnormal result. Next. So they basically looked at 85% screening in those who were actually screened. And then when you look at those who were in the control arm, which is supposed to be no screening or the standard of care, 52% were screened. So you're actually comparing 85% to 52%. You're not comparing screening versus no screening. So they could not find any mortality benefit. And they basically found that the complications from the PSA or the DRE are minimal, but the biopsy had complications, infection, bleeding, retention. Even 1 in 1,000, they might die from a transrectal prostate biopsy. Next. Next as well. Next, we're gonna go to the limitations. So basically, the other issue and this is where the urologist would look into this, and this was the problem with the task force, that okay, we said 85% versus 52% of the screening, but then those who were screened, out of the 85, 41% of those who were supposed to be biopsied were not biopsied. Sorry, 41 were biopsied within a year. So so I would say 59% were biopsied after a year. So imagine you were found to have PSA that's high. You need a biopsy. I think, we're gonna do a biopsy for you, and it gets done after a year. And then when you look at the median follow-up for those with the prostate cancer, it was 6.3 years in the screening arm versus 5.2 years in the control. So this is such a short follow-up to be able to tell that those who were screened versus those who are not were actually going to benefit. Because even if you develop metastatic prostate cancer, you might live up to 5 to 7 years without even any problem. Next. So this one here now, this is called the Godberg study. This is actually part of the European study. This is from Sweden. So it was in the center in Gothenburg in Sweden. They had 20,000 men between 50 and 64. And remember, like each center had their own strategies. So they screened every 2 years until the age of 67 to 71. And they had initially a cutoff 3.4. Remember when I said if you lower the cutoff, you will be able to capture more significant prostate cancer. So they went from 3.4 initially, and they went down to 2.5. And then those who were screened, 93% compliance with the biopsy. Next. So patient treated according to the discretion of the physician, for sure. You don't have to, you cannot force a treatment. The patient can follow, can look at, can have active surveillance, can do whatever. They linked the deaths with the Swedish Cancer Registry and death certificates, and they had a longer follow-up. The median follow-up was 14 years. Next. Now they found prostate cancer higher in the screening group, 12.7 versus 8.2. They found that there was lower mortality in the screening arm by 44%. And when you correct for the amount those who are actually screened, it becomes 56% lower mortality in the men who are actually screened, this specific mortality. Next. You can see the curves, like the graphs are apart, are like moving apart. Next. Same thing here. Next. Now, when we look at the Goldberg study, the number needed to screen in the European study was initially 1,400. Now, and number needed to treat was 48 and then went down to 39. In the Goldberg study, you need to screen 293 and you need to treat 12. So this is very significant. This is not as bad as the other study was showing. But again, this is when somebody knows what they're talking about. They are urologists. They know what are the issues of these studies. Next. So we have to remember, this Goldberg study is part of the European, but it's diluted among the 160,000. It's more homogeneous population, longer follow-up, younger population, and basically, this is why it was showing a significant aspect. And this is a sub-analysis or subgroup analysis because it's part of the bigger study. Next. So they basically, when they modeled the European study for the screening versus not, they found that screening caused 9 fewer prostate cancer deaths, and you have a total gain of 73 life years gained, 8.4 years per person per death avoided. So if you have a grandfather, if you screened him, you would probably, if he's going to get prostate cancer, you probably gave him 8.4 years extra. That's a lot. Next. And also then when you do it for the quality of life, basically there's also a benefit from that aspect, because also when they're not having metastatic prostate cancer from the get-go, they fare better. They don't have as many visits to the emergency. We even have I call it a non-ethical study that came back from also, I think from this, we call it the Scandinavian study, when they had patients prostate cancer, treatment or no treatment. I don't know how this passed ethics, but this did. And they found that patients who did not get treatment, they had worse deaths because they were always having more complications, nephrostomy tubes, and worse stuff basically happening. Next. So what about in Canada? I'm going to try to go very fast, fast, because I want to have some time for the questions. So we have our guidelines. I sat on I was part of the CUA guidelines committee for 5 years. I finished my 2 terms last year. This is basically the urologists in Canada. They take the world and the Canadian data and they present it and in the Canadian context. Next. So next, please. Yeah. So the CUA suggests basically if you have a patient who has life expectancy more than 10 years, it's a discussion. We're not saying you should do it. It's a discussion between you and the patient talking about the benefits and the harms of the screening. And this is fair. I don't think nobody should force any screening on anybody. Next. Now, during the same year, when this one came out, the US task force came out and actually they shared that they changed their stance. The one that said we should not be screening, they changed their stance in 2018, but this was not published. They said like, oh, we're changing our stance. You can actually do it. I think it was published later on. I did not update it into my study here, but basically they said, oh, well, it's a discussion, which was any screening is a discussion. Next. The Canadian Task Force is weekly recommending against the PSA screening. Again, old studies, not updated. I don't take this for anything at all. Next. Now, for men undergoing PSA screening, PSA testing at the age of 50 in most men, or at the age of 45 for those who are having increased risk. So those who are having a father or brother who had prostate cancer, those are having increased risk. Those are the ones we recommend doing one PSA at the age of 45. Next. Now, if you're going to go PSA screening, if your PSA is less than 1 initially, you can do it in every 4 years. 1 and 3, you can do it every 2 years. And more than 3, I would be like doing it at a shorter interval. Maybe I would go initially every 6 months to see the velocity, and then if it's stable-ish, I'll do it in a year or so, and then we go from there. And that's this grade C recommendation. Next. Men who are having PSA screening, if they're at the age of 60, less than 1 of a PSA, no more PSA. For all men, other men, discontinuing the PSA screening at the age of 70. Now, you have to remember, this came out in 2017. And we're saying 10 years of life expectancy. Now, the life expectancy in the Canadian male is longer, is more than 70. It was not like 77 or 80. Now it's at a bit higher. So I would say you can do the screening in a man who has more than 10 years of life expectancy, period. This is in my opinion, myself. For men with less than 10 years, please do not do it. If you have somebody with heart failure, like today I had a guy with heart failure, like humongous ulcer in the back, multiple admissions, very frail, and somebody in the hospital did a PSA and came back to be 10.8. I'm like, and then actually later on it was repeated, it came down to 5, then came down to 1. But why even the whole exercise? Why do we even do a PSA on this guy? Next. Patients who are having elevated risk of clinically significant prostate cancer, basically based on the PSA, who are biopsy naive, the multiparametric or doing an MRI, like what we do, like basically an MRI targeted biopsy, should not be considered as standard of care. Now, this is the COA guidelines, and we have to remember that this is very, very a political statement, because we cannot go out and say we should do MRIs from the get-go. And I'm going to talk about this because Cancer Care Ontario gave a different recommendation. Why? Because imagine now all the patients everywhere, they're going to say, well, I do not want to have the biopsy like this. I want to have an MRI. How many patients are going to have an MRI? And we don't even have enough MRI scanners. It's going to be a problem. So this is why this came out this way. But the reality is now this CCO has said you can actually have an MRI before having your biopsy. I'm not saying we're going to do an MRI on every man. No. But if you're going to have a biopsy, maybe an MRI before that would be better so that it can guide us better. Next. If you had a previous negative biopsy, then an MRI would be a good option. And I think this is basically what many people do. Next. Now, looking at the PSA kinetics, peak-total ratio, it should not be used alone, as I was saying. They can be helpful to make your decision later on. Next. And then, as I was saying, all these like fancy tests, they're not funded and they're not widely used. And I would not be recommending this for anybody in the primary care setting. Next. Biopsy or not is a shared, informed decision between the patient and doctor. And we need to understand that, yes, we can have a patient who had a bad experience, we can have a patient with an amazing experience, but in the end of the day, it's a decision between by the patient, and the patient needs to be properly informed. Next. Now, the MRI in Ontario MRI now is acceptable prior to thrust biopsy, implications on the wait list. That's why, for example, at least here in Northern Ontario, we said it's going to only be ordered by the urologist. This way, we don't have a huge pressure on the MRI machine because we don't have the same access. And you need to have a proper quality MRI, and you need to have a proper radiologist, because not every radiologist who reads MRIs can read the prostate MRIs. They are specific and they have the PIRAT scoring, so it should not be something that's just ordered by everybody. Next. So what about Northwestern Ontario? Right now, so we are lucky. When I started here, I had the issue, we started initially with the DAP, because I saw like our patients getting delayed treatments, delayed access. It was like there was no screening, so we did the DAP program. Then we were lucky, we were able to get we advocated basically for a newer machine to do MRI fusion biopsies, where basically we bring the MRI scan, the scan from the MRI that shows the lesion, and I have the ultrasound, and I superimpose the two images together, and I directly go at the lesion with an ultrasound, and I hit it. So this was transrectally. So still, we have the high risk of infection. We have high rates of infections and admissions and ICU admissions sometimes. So we were able to even move ahead with what we call transperineal prostate biopsies. And actually, we're lucky we can do transperineal regular or with fusion, which means with the MRI. And this is basically, we put the ultrasound probe in the rectum, but the biopsies are not going from the rectum, they're going from the perineum. And this is actually our data. We submitted this data for the Canadian Urology Association and for the American Urology Association. 39 patients done from May 2023 until December 2023. Not a single infection, not a single hospital admission. Had a couple who had vasovagal. One had not even during the procedure. One had it after he went back to his room and was leaving. 66% positive, rate of positive results. 36% were with low intermediate prostate cancer, and 30% they had high grade cancer. So the rate of finding positive cancer with the transperineal is higher because the cores are going in a different way. They're not going from the rectum, so they're going along the axis of the prostate, which gives us better cores. Next. So this is where it's important, I think, for our regional colleagues to know what's happening with our region now. So how are we doing with our regional patients? This is a study done by our group. When I came in, I noticed there was an issue with our regional patients. The presentation is different. So we had a total of 1,400 patients over 10 years with prostate cancer. And we tried to look at the distance and how is their presentation. Demographics were not really much, there was not really much of a difference. Maybe some of them are more married than not, but this is not something that really affects us. And definitely you can look at the average distance or how far away they are from the cancer center. Regional patients on average 451 kilometers, patients who are in Thunder Bay 33 kilometers. But then once you start looking at the characteristics of their presentation, this is where it gets really interesting. So you look at the PSA on presentation. The median PSA on presentation is 13.2 for the patients who are living far away, while it is 9. So basically, automatically on presentation, the median, you're already in the intermediate risk prostate cancer, because if your PSA is above 10, between 10 and 20, you're in the intermediate risk prostate cancer. If you're less than 10, you're in the low risk. So without even saying anything, the median is already higher for the regional patients. Now let's look at prostate, the Gleason score. You already see that there is significantly higher Gleason score. You can see actually the above 6 is higher in the regional patients, while basically the opposite for the patients who are in Thunder Bay. Now let's look at the stage at the presentation. Like when you just doing the staging, is it localized versus advanced? Significantly higher, 25% or 26% are advanced in the regional group versus 17 or 18% in the local group. How, this is just not even metastatic. Now, what about metastatic? 22% are metastatic on presentation in the regional patients versus 14.6% in the local group. So this is already very significant finding. And actually, if you look at the likelihood of advanced stage of diagnosis, you're basically talking about odds ratio of 1.8 if you are in the region compared to basically in Thunder Bay. Next. So then we wanted to look at basically the choice of treatment. Is there going to be a difference between the regional patients and Thunder Bay patients in their choice of treatments for the same stage of disease? So we started. I thought initially myself when I was like having my hypothesis that we're going to have more patients from the region going for surgeries. Surprisingly, not. Actually, more of the regional patients went for radiation. We tried to find an explanation. We thought it might be because those regional patients, maybe they're concerned, they get the surgery, they go back, there are no surgeons down there right there who would help them, and they wanted to avoid the complications. But this was an interesting finding. Next slide. Now, when you look at in the low risk, there was not really much of a difference. But once you start talking about high risk, there is a significant difference between the patient groups basically for the treatment of choice. And surprisingly, like you can find even higher patients in the region going for active surveillance for high risk localized prostate cancer, which is treatable, but they go for active surveillance, which is not guidelines driven at all. And for the intermediate risk, you can see this is where we found it interesting, that where we usually have a balance between the surgery and the radiation. In the region, they were going more towards the radiation, which is opposite to what the patients were living near Thunder Bay. So the question comes here, like I'm saying, if you look here, I'm saying 300 and less than 300. The reason we came up with this number is that when we looked at the distribution of the data, we found that 300 kilometers, and this is where basically you'll find Dryden, Fort Francis, and Kenora. All these are above that, and the pockets are usually like that are closer. They usually go to Thunder Bay, so it's not as it is not as like, and it makes more sense because these patients come easily to Thunder Bay. Next slide. So this is the heat map, and this is where it becomes very interesting. This is a percentage of the patients. Like, if we're not talking about all the patients, like we're talking about if you have let's say, for example, I'm going to make an example of Thunder Bay. Let's say in Thunder Bay we have 600 patients, 700 patients. How many of those, what is the percentage of those patients who presented with metastasis on the initial presentation? If you're above 50%, you're red. If you are orange, you are between 25 and 50. You are yellow if you're less than 25%. And you can see easily right now, the further away you go, the redder you are, which means that those patients are, like, imagine if you have 10 patients from Sandy Lake or 4 patients from Sandy Lake, 2 of them are coming with metastasis, as compared to other places, again, who are having lesser, not a percent or a smaller, like a much lower percentage. And this is significant because this means that those patients are either not getting screened or they're not getting the access fast enough to get their cancer diagnosed faster and earlier. Next. So before we go back to our clinical scenario, I think this data, these slides show where we are, and we want to be better than this. We want to make sure that our patients are getting better access. Again, I'm not saying everybody should go and get screened, but you know what? We do like a men's health event every year in September. Any man above the age of 50 can come in, or actually any man who wants to come in and have a rectal exam and PSA screening. Now, actually, the rectal exam question is actually becoming very, very debatable. There are a couple of 2 major studies that came out saying basically, let's just forget about the rectal exam. If you have a PSA, it's more than enough. We have PSA, we have MRIs. We don't really need to do rectal exams. And I think it is not a wrong thing to do, but in the same time, also we do not want to be losing the skill to know what we can find and what we cannot find. So going back to the clinical scenario, can you go next? Now, this patient who's having these symptoms, first of all, is this PSA, if you're going to do a PSA on this patient, is it going to be a screening PSA? Think about it for a second. This is not a screening PSA. This patient is having lower urinary tract symptoms. At this point, doing a PSA is not screening because this patient might be having prostate cancer. It's not a patient who's coming to you without any symptoms coming in for their annual checkup and you're doing a PSA. This is a patient who is coming with lower tract symptoms. Those patients would benefit from a PSA. Now, does this patient need an ultrasound? Not necessarily. If you're having BPH or lower tract symptoms, you do not need to have an ultrasound in the beginning. What needs to be done? I would say rectal exam, just to get an idea about how big is the prostate, and PSA, and doing an IPSS. This is how you're going to know how bad the symptoms of this patient are. Like, how bad are these symptoms, right? Are they actually quite bad or are they good? We'll be able to tell. Now, starting the patient on tamsulosin, you know what? If the patient is coming in with worsening symptoms, it means that they're bothered. But actually, part of the IPSS is asking them how bothered they are. How many times I have patients who are having high IPSS, and then I ask them, "Are you bothered?" Like, no, I'm good. Like an old Italian man, he's happy waking up at night 4 or 5 times. I'm like, okay, it's your business. He's like, oh yeah, I go to sleep well. I have no problems. So if this is the patient, why would I need to push on them a drug? Again, remember, tamsulosin can cause them to have orthostatic hypotension. They can fall. Doesn't mean I don't give it, but again, it's a discussion. So overall, I hope that this hits some points, and I'm happy to have any questions.
Yes, doctor, we have a question from Lynn Sholey. She says, thank you for this very friendly and informative talk, Dr. Sharur. Is there a PSA level, assuming other normal test results, that would signal the definite need for a prostate biopsy? For example, how high is high? More than 4, 10, or 15?
Beautiful question. I don't have a number for this. Why? Because if I get a number that is high, I repeat it again. It's not. So I always tell the patient this scenario. If a patient is coming to me with a PSA of 15 or 20, I'm like, okay, you're already, if it is prostate cancer, you're already in the intermediate risk. What difference is it going to make right now if I can just wait for a few more weeks and repeat it again? What if this was an abnormal result? The PSA takes the half-life. If you want to see if there was an abnormal rise, wait for, actually, it takes up to 30 days to get into a normal level from an abnormal rise. So I repeat the PSA again in a month and I see. Now, and again, if it's your patient in your setting, in your primary care setting, this patient got a PSA, came back high. Oh, okay, let's repeat again in 1 month. Now, this patient came back with a 30 PSA. I will repeat the PSA again, but I also refer to urology. Now, the question is, at what level am I going to refer to urology? You can refer at any setting that's above 4 or 5 or 4. But the question is it actually a true rise or not? Is it a true 5? I would repeat again. It's not going to be the end of the. You can always wait. It's not like you don't have to refer right away. You can wait, do another PSA, and then at this point, when you're sending the referral, you're sending 2 results. It will make things faster for the patient, because what happens in those cases, you send the referral, and we repeat the PSA again. The only time I would biopsy someone from one result if I have a PSA that's in the hundreds. And actually, even in those kind of cases, okay, I'm going to book you for the biopsy. I'm going to get another PSA anyway for the time being to make sure it is truly like that. Because those patients, I'm like, okay, you're very likely to be metastatic prostate cancer. I want to get things going, and I want to get things done fast. So I always repeat PSAs. I don't send a PSA from the get-go. And after a second result that is still high, yeah, I would refer. And then your question is, at what level? Above 4. If you want to be like, follow the guidelines, above 4. And this is the medical legal thing. It's like, this is the 4, the standard from the North American, although even in Canada we have it lower, but above 4. And now if you want to do the age cutoffs, I would recommend that you leave this for the urologist to the age cutoff. This way, like if you have a patient who's 70 who has a 4 or 4.5 and another one that's 4.7, you send them to the urologist. What I'm going to do, I'm going to tell them, listen, your PSA is not that high yet. It's elevated more than the usual, but for your age, it's acceptable. I'm not going to let you go. Maybe you're starting to do something, like you're starting like a cancer right now. I'm going to repeat a PSA in 6 months, and I'm going to see. So this is how I deal with it from my perspective. I don't really jump on the biopsy. Now, if this same number, 4.5 and 4.7 in a 45 years old or a 50 years old, this actually I'm going to be offering them a biopsy. Or actually, I'm going to offer them an MRI first and then a biopsy. So the difference is that I use the cutoff, the age cutoff, to kind of guide me where am I gonna like how serious is it from it is from me.
I don't see any hands particularly. If there are any questions, though, if people feel comfortable, feel free to unmute and ask, or also just to continue to put them in the chat. We have another one in the chat. How much can PSA be elevated by sexual activity?
It depends on the patient, but sometimes I've seen it going up as much as like 3-4 points. Sometimes it's one or 2 points. If the patient tells me that they had sex in the previous 3 to 4 nights, or at least 3 nights before, I tell them, we'll repeat again, please abstain from sex for at least 4 to 5 days. This way I don't have to worry about any of that. And I don't think a DRE raises your PSA. DRE, unless you're, I don't know what kind of DRE people would do to raise a PSA. Like, they really have to be really digging hard in this prostate, and I don't think anybody does that anyway. Depends. It's actually, I have a quick thing I would say about the prostate. I have when I was a resident in McGill, there's Dr. Taguchi, very big figure in urology, and he used to say that God made the prostate to punish men, because there is no, like, it could have just easily been a small duct or something, like, just producing some of that, but it was made around the urethra to compress the urethra and cause all this kind of trouble for men. So the prostate is the gift that keeps on giving, and that's the problem. I hope everyone found this informative. And again, I'm more than happy if anybody has any question at any time, please call me, call my office. I'm more than happy to pick up the phone and talk and discuss a case or anything like this. This is our job, and this is what we want to do, and we want to increase the awareness.
Thank you. So I do have a question actually myself. Is there any further discussion, just given the updated data around, say, around being able to expand criteria for funded PSA?
The problem here is that you are talking government, and this is where when I always talk to, whenever I have a whole bunch of men with me, in the prostate cancer patient group, I always say that men are not vocal. How many times we see women with breast cancer, shaved heads, and walking around and saying, you know what, we need better stuff for our breast cancer and research and all of that. Men are not going to walk around saying, I'm peeing my pants, we need more care. It doesn't work this way. So when we talk about politics, once you start talking about PSA, it's money, it's repeated, it's expensive. The government does not have this interest to pay this amount of money for now. And men are not very vocal as patients to say, you know what, I suffered because of my prostate cancer and I need the treatments. And the simplest example, men who are having prostate cancer and they get radical prostatectomy and they have incontinence, the device to give them, the one I put, which is called the sphincter, to give them continence, which is horrible. Like, imagine living in your piss. It's $10,000 to $12,000. It's very important. It's lifestyle. While having a breast reconstruction, and I'm not denying that breasts are important psychologically and for many other reasons, but this is just a breast reconstruction post mastectomy, is covered. Well, the sphincter is not covered. So a man would live with in his urine, not covered, while having the breast reconstruction is covered. How? Like, it's not right. Our system is not made right. And I'm not saying, and by the way, it goes the opposite way. You look at urology, I do a penile lesion excision, I get paid maybe $70, $80, while a woman gets her cervical lesion removed for $39 or $32. So our system is not made right, and this is the problem. It's an administrator that sits and decides, and this is where we have a problem as a system. And it's not going to change anytime soon because it is not interesting. It's not sexy for anybody to talk about people in their diapers.
Thank you so much. I think this has been a very valuable, very valuable talk, and I hope many people will be able to see the recorded session as well, and the data you've presented with respect to the differences in our region are really astounding and I think very important, both from provider level and as well for patients to understand. So thank you very, very much again.
Thank you. Have a nice weekend.
Thank you, everybody. We really appreciate you being here and attending the webinar. If you have any further questions, like Dr. Sharoor said, you can either reach out to his office or you can send me an email. I left my email in the chat box below. All right, that will be all for today. Thank you so much. Bye-bye.
Thank you.